All right, so I think we have enough people to get started. So welcome everyone. I'm just going to go through a couple reminders and then I'm going to pass it on to Scott Triedman. But welcome to our first PIH cross-site joint oncology project ECHO series. For those of you that don't know, my name is Erin, and I am the oncology associate here at Partners in Health. And so just a couple of reminders. We are recording the meeting. Please remember to mute your microphone if you are not speaking. If bandwidth permits, we encourage you to turn on your video just to make the session a little bit more interactive. And we encourage you to use the chat at any time to introduce yourself, ask questions, or make comments. We will be doing question and answers at the end, and so feel free to type your questions into the chat. All right, so I'm going to pass it over to Scott to give a little bit of an introduction about our session, and then we can have Dr. Sarah Slater give the lecture.
Great, thanks, Erin, and good morning, everyone, and welcome to our first, what hopefully will be a bi-monthly joint PIH Oncology ECHO. This morning, we're really actually very thrilled to be joined by our many colleagues in Rwanda, Haiti, Lesotho, Liberia, and also Boston, I believe, as well. It's exciting to see you all in your little black boxes and your faces this morning, and we're excited to launch this. Although we've been doing weekly tumor boards and clinical lecture series and various ECHO conferences for lots of years now, to my knowledge, this is the first time that we've brought together all the teams that the Dana-Farber Center for Global Cancer Medicine works with for this really a system-wide oncology ECHO series. And our hope is that this conference is going to expand on a number of topics that come up in our tumor boards, but don't really ever get enough time to delve into more deeply. And a lot of them really deserve a lecture of their own. So we've been trying to come up with topics. We have the next few meetings set, but I do really encourage you all to circle back if there are specific topic ideas that you'd be interested in learning about for future ECHOs, because we're always looking, and we're looking to maybe go outside of our clinical team eventually to bring in other expertise as well. I feel like we've been kind of building this plane as we're flying it, as they say, and we really depend on all of you to give us guidance here. Before we get started, the one thing I wanted to do was to recognize and thank Erin for really doing all the hard work to make this series happen. As I think all of us probably know, this kind of effort doesn't just happen on its own. People make it happen, and in this case, it was Erin. So thank you very much. Without any further ado, I'm going to turn this back to Erin and then on to Dr. Sarah Slater, who's going to teach us all about pregnancy and cancer this morning or this afternoon, depending on where you are.
Well, thank you, Scott. Just a little note before we get started, just for background, you've probably heard the word ECHO a lot in the past few minutes, but for those of you who don't know, ECHO stands for Extension for Community Healthcare Outcomes. Project ECHO is now all over the world, but it started 2 decades ago to help primary care physicians treating patients in rural New Mexico. And it worked to connect specialists with those primary care providers to provide the most up-to-date standards of care. ECHO uses a hub and spoke knowledge sharing network through virtual conferences to translate new knowledge into practice. And the ECHO model uses case presentations followed by didactic lectures. And so we're going to get started soon, but just before we do, I wanted to quickly thank Dr. Nikase as well from the Rwanda team for allowing us to use his case in the presentation today. All right, so then I think we are ready to do the lecture. So I'm going to pass it off to Dr. Sarah Slater. She is a medical oncologist at the Dana-Farber Cancer Institute. and works with our Center for Global Cancer Medicine. So Sarah, take it away.
Thanks, Erin. And thank you to Scott and Nikase and everyone that's involved in helping to put this together today. I am a medical oncologist. I work at Dana-Farber, and I've been very lucky to help support the Rwanda and Haiti teams in their oncology clinics over the last several years. And we're really excited today to bring the PIH teams together because this is not something that we get to do on a regular basis. And I also want to welcome our other PIH colleagues who do not work in the oncology space with us. I think this is a really great opportunity to bring everybody together, both in the oncology clinics, at other sites where maybe we don't have oncology clinics yet, but that we may, have developed in the future. And also, I think that this particular topic is something that our non-oncology colleagues may encounter in their practice. And it's something I think that is universally scary for clinicians when they provide. So hoping to talk about this and provide a little bit of education about how to manage cancer in pregnancy when we see it, and how to counsel patients and become a little bit more comfortable, which is, I think, something that we can all appreciate when we're dealing with challenging situations. So just to advance the slides, as Erin was saying, this is an ECHO project. We have no disclosures to report. So the objectives of our talk today is to help understand what the most common malignancies in pregnancy are, how we want to approach a diagnosis of cancer during a pregnancy, what some of the challenges might be, what the treatment options are for these patients. We want to talk a little bit about chemotherapy and how we incorporate that into their care, and then also which therapies should be avoided. So we're going to talk about this, I think, mostly through the lens of breast cancer. That's to acknowledge that a different type of cancers may be diagnosed in pregnancy, but both our Haiti and Rwanda teams see breast cancer most commonly. And we wanted to have this discussion utilizing a case that the Rwanda team had brought up. So this is a case that they presented back in the fall, in October, of a woman that came into clinic. She was a 40-year-old woman, G7P7, who had a new finding of bilateral breast masses. Left breast mass was quite large and had skin ulceration with bulky left-sided axillary and supraclavicular lymphadenopathy. And she also had a right breast mass, which was smaller, but also had associated lymphadenopathy. Both of these were biopsied and were consistent with invasive ductal carcinoma, which was grade 2, ER positive, but PR and HER2 negative. And during the course of her evaluation, she had an abdominal ultrasound, which showed multiple liver lesions, which were highly suspicious for metastatic disease. And this patient was started on palliative chemotherapy. In this setting, she received paclitaxel and had a good response to chemotherapy. So decrease in the size of the breast mass and skin ulceration after 6 months of chemo. And so the team, seeing her good response, decided to switch her to tamoxifen. And when she came in to follow up with the team, after being on tamoxifen for 2 months, she was found to be pregnant. And she was at 7 weeks gestational age per ultrasound. So this is a situation that doesn't happen commonly. But when it does, it causes a lot of anxiety and distress. So this here is the distress meter. And these situations tend to generate a lot of worry. So worry on the part of the patient, worry on the part of the clinicians. And so when this happens, I think the first step is to try to pause and kind of reassess the situation, and I think try to, as much as possible, decrease the anxiety in the room. This is not something that happens commonly. So breast cancer, cancer and pregnancy in general is pretty rare. We see it in about 1 in 1,000 women. The most common type of cancer we see in pregnancy is breast cancer. But we also see cervical cancer, melanoma, and hematologic malignancies as well. We have seen an increase in breast cancer in pregnancy, and this is data from the United States. And we see that the average age that breast cancer in pregnancy is diagnosed is in the mid-30s. And we think that this is related to delayed childbearing, so women having children slightly later in life than maybe previously seen. As we've acknowledged, this can be very challenging for the patient and her family, as well as the care team, because we are now balancing the health of the mother with the health of the fetus. And this is an area where we really don't have a great standard of care. So there's very limited data to guide our decision making. So we're basing a lot of our recommendations on case reports and case studies, or historical cohort studies, but there are really no randomized trials that are guiding our decision making. And so we need to consider each case, each patient individually. And I think one of the key things we want to talk about is sort of what are the patient's goals? So when we talk about what to do and how to best manage this, we want to keep the patient at the center of this decision making. So I think you need to have an honest conversation with the patient and their family about what to do next. So for some patients, they may choose not to continue with the pregnancy, depending on where they are and what the stage of their illness is. And if the patient decides to continue with the pregnancy, then we really advocate for a multidisciplinary approach in order to assure the best maternal and fetal outcome. And so this is a time where you really want to enlist your colleagues. So as an oncologist, I want to make sure that I'm communicating well with the OBGYNs, with the surgeons, with primary care, with the other specialists that are going to help us best care for the patient. I would also add that incorporating help from the mental health teams, psychology teams, and also potentially genetics may be very helpful. But I think that communication is really key, and having consistent messaging as a team can be really helpful in reducing the anxiety for the patient and her family. So one of the things that we often see in this scenario is that there may be delays in diagnosis. So patients may present at a later stage of their cancer when cancer is diagnosed in pregnancy. And that happens for a few different reasons. So some of the signs and symptoms that we might see in cancer may be attributed to somebody's pregnancy.
So you are saying you have problems with
for example, nausea or fatigue, changes in bowel habits. Those may all be attributed to pregnancy. And so the team caring for that patient may not be thinking about cancer. And there are changes in a pregnant person's body, for example, changes in the breast tissue that may make physical exam less reliable, and again, contribute to things being diagnosed at a later stage. I think also when a woman is pregnant, providers often are less likely to recommend diagnostic evaluations. We tend to avoid scans or procedures in a pregnant person because we're trying to avoid any unnecessary risk to the fetus. Other things that may cloud the picture would be things like tumor markers. So tumor markers can be less reliable in pregnancy. So certain tumor markers are normally increased in pregnancy. And so we can't really use those to help us in the same way as we might in a non-pregnant person. So when a woman is diagnosed with cancer in pregnancy, we need to proceed with staging as we normally would in any newly diagnosed cancer patient. But staging poses a unique challenge in this situation because we generally want to avoid unnecessary radiation to the fetus, especially in the first trimester, given the concern for fetal malformations. So in this situation, utilizing ultrasound and MRI are recommended if those modalities are possible. As a note, MRI contrast, which is gadolinium, does cross the placenta and is teratogenic in animal studies. So we generally don't recommend using gadolinium if possible to avoid it. Mammograms can be done. They're considered relatively low risk if they're done with abdominal shielding during pregnancy. The same is true for chest x-rays. So in order to stage the chest appropriately, we would use a chest x-ray, again, with abdominal shielding. CT scans should be avoided because of the, and PET CTs for that matter as well, if those are available, because of the much higher radiation exposure that's involved with those studies. And just as an aside, iodinated contrast should also be avoided, as that also crosses the placenta and the effects on the potential fetus are not really known. So once we have a diagnosis and stage, how do we make recommendations for somebody? And I think that there are several things that we need to consider when we're trying to formulate a care plan for these patients. The first is the stage and the prognosis of the cancer. So if a patient has a very early stage breast cancer, we are going to think about that patient differently than we might a patient that has metastatic breast cancer or metastatic colon cancer. So we always want to consider sort of what the likely disease trajectory would be. And then we want to think about the clinical status of the patient. So if a patient is very sick, if a patient can't wait for treatment of their cancer, then that is a different discussion than a patient that has an earlier stage cancer, who we can maybe get through the pregnancy utilizing more minimal risk interventions. Another thing to know when you're having these discussions is what the gestational age of the fetus is. So if a patient is very early along in their pregnancy, the fetus is more susceptible to the toxic side effects of, say, chemotherapy, as opposed to a woman that's further along in their pregnancy. If it's very early on in the pregnancy, the termination of the pregnancy may still be an option for that patient. We want to be able to counsel them a little bit on the associated fetal risks with each of the proposed treatments. Again, recognizing that we don't have all the data we would want in this situation, and a lot of the data we're extrapolating from case studies. But that's sort of the best information that we have. And then again, to come back to which I think is the key component here are the patient's goals and preferences. So I think you don't know unless you talk to the patient and ask them what their goals are. So some patients might say, I want to continue this pregnancy at all costs, no matter what, even if I don't survive. Other patients may take an opposite approach and say, I would rather focus on my health and I'm not as worried about the health of the fetus. I think most people fall somewhere in between, depending on their desire to continue with the pregnancy. And ideally, we want to optimize outcomes for the patient and for the fetus. And I think another issue that comes up is a patient's desire to preserve their fertility. And that may be an issue, particularly for GYN cancers, that may be managed postpartum with resection, such as a hysterectomy. So what are the usual treatment options? So when we think about treating cancer, it's usually a multidisciplinary approach, and we utilize all the members of our team in order to for the best outcomes, really. So the things we commonly use are surgery, radiation therapy, and systemic therapies. So systemic therapies include chemotherapy, but also hormonal therapies, endocrine therapy, and more targeted agents as well. So for surgery, surgery is generally considered safe during pregnancy. So the risk of miscarriage or major birth defects is very low. And anesthetic drugs actually have a pretty good safety record in pregnancy, and they don't have a documented record of teratogenicity in humans. So in general, the consensus is that surgery is fairly safe. The timing of surgery is basically based on need. So if a patient requires urgent or emergent surgery, the recommendation is that that should be performed regardless of trimester. If that surgery can be delayed, then usually we would recommend waiting until the second trimester, again, just to avoid any potential risk that the anesthetics could pose to the fetus. And then just thinking about the timing of things, for example, if there's an abdominal surgery that a patient might require, that might be easier to perform in the second trimester rather than the third trimester, given uterine size. Although performing a surgery very late in the pregnancy, it is associated with a slight increased risk of preterm labor. So that's something to consider, again, when we're looking at the timing of these interventions. Radiation therapy is something that we often incorporate into our cancer care plan. However, in general, radiation would be avoided throughout the course of a pregnancy. So radiation that's delivered to the pelvis very early on in a pregnancy can result in spontaneous abortion and is associated with fetal malformations. And exceptions to this might be, if delays in radiation are going to compromise treatment efficacy and be a threat to maternal health. The other areas where radiation are often used are oncologic emergencies. And so that can include spinal cord compression, SBC syndrome, brain metastases. And in those situations, the life of the patient, of the mother in this situation, may be at risk. And so it's definitely a conversation and weighing risks and benefits. But radiation therapy may be considered in those situations in order to prevent significant morbidity and mortality of the patient. The next sort of tools in our toolbox would be systemic chemotherapy or systemic therapy. And so in this particular situation where we have a patient with metastatic breast cancer, we're talking about chemotherapy and also hormonal therapy. We're also going to talk a little bit about targeted therapy, in particular trastuzumab, which is used in our HER2-positive breast cancer patients. So going back to the case from the Butaro team, so after the oncology team found out that this patient was pregnant and she had been on tamoxifen, they met with the patient and her husband. They recommended discontinuing the tamoxifen, given the potential teratogenic effects that tamoxifen can have. And in that discussion, the patient had wanted to terminate the pregnancy. However, her husband disagreed with that. And so the initial decision was to stop tamoxifen, wait until the second trimester, and then to resume treatment with palliative chemotherapy. So to resume the palliative paclitaxel, which she had been tolerating and had a good response to previously. So let's talk a little bit about chemotherapy during pregnancy, because this is something that makes everybody nervous, the OBGYN team and the oncology teams alike. So when we think about utilizing chemotherapy, the gestational age of the fetus and the timing of the chemotherapy is very important. So in the first trimester, chemotherapy is associated with a significantly increased risk of congenital malformations, up to 20%. The rate of spontaneous abortion in the first trimester following chemotherapy or exposure to chemotherapy is actually similar to the rate of spontaneous abortion in healthy women. It's about 13%, although those numbers are a little bit difficult to track. But the thing that we worry most about are these congenital malformations. When chemotherapy is started later, after the 14th week, the risk of malformations is pretty close to the general population. So chemotherapy becomes much safer for the fetus if it's delivered in the second or the third trimester. There is a slightly increased risk of stillbirth compared to the general population, but that's usually seen in patients who are being treated for hematologic malignancies. And that's attributed in part to the medications that are used in the setting of, say, acute leukemia, and also the disease itself. So the mortality is much higher with acute leukemia than is for an early stage breast cancer. Chemotherapy may affect fetal growth, and so there is a slight increase of having a fetus that's smaller for gestational age. One of the other worries about chemotherapy is it can cause myelosuppression in the newborn. So sometimes babies can be born with low counts. That's usually a transient phenomenon, but something to be aware of, especially for the OBGYN team that may be caring for the child after birth. This is just basically a slide to show the gestational age effects of chemotherapy sort of based on the trimester. And this reviews what we were saying, that, you know, in the first trimester, the fetus is undergoing organogenesis. And that's really the highest risk time for malformations. And this is the time where we really want to avoid neoplastic drugs, if at all possible. I think that, again, this is always a risk-benefit situation. And there may be times when a woman presents with a cancer in pregnancy where not starting a patient on treatment may result in the death of the patient. And so these are not absolutes. There are times where you might consider utilizing chemotherapy, even if it's early on in the course of the pregnancy. Because we're focusing our discussion on breast cancer, I just wanted to refer to the breast cancer chemotherapy drugs that we commonly use and their sort of safety profile in the setting of pregnancy. So we utilize doxorubicin, which is an anthracycline. It causes DNA damage through the inhibition of topoisomerase II, as well as other mechanisms. It is considered okay to use during the second and third trimester. There is an increased risk of cardiomyopathy, of dose-related cardiomyopathy in patients that we treat with doxorubicin. And the concern was that this may induce cardiomyopathy in the offspring, in the fetus. But as the data we have available to us at this time is that it doesn't pose a significant cardiac risk to the fetus. It is excreted in breast milk, so after delivery, if a patient is being treated with doxorubicin, we would discourage breastfeeding. Cyclophosphamide is another component of our chemotherapy care for these patients, for breast cancer patients. And cyclophosphamide exerts its effect by cross-linking DNA strands, and is also okay to use in the second, third trimester. It's cyclophosphamide and metabolites are present in breast milk. And again, it should be avoided after delivery. The last sort of commonly used drug for our breast cancer patients in Haiti and Rwanda is paclitaxel. Taxol is actually derived from an evergreen that grows in the Pacific Northwest. That's what it looks like. And it targets microtubules, which affects the mitotic spindle in dividing cells and results in cell death. It is also considered okay to use in the second and third trimester. It does not appear to increase perinatal complications for the mother or the fetus, and also should be avoided in breastfeeding. So those are the three sort of most common drugs that we use in our oncology clinics in Haiti and Rwanda. There are other chemotherapy drugs that are used for different types of cancers, and they have different profiles. So I think if a patient is diagnosed with cancer during pregnancy, you have to look at all of the drugs in the regimen and make your decision based on those toxicity profiles and what you think will offer the best outcomes both for the patient and also for the fetus. Because chemotherapy is associated with a small for gestational age infants, the recommendation is to do weekly ultrasounds when patients are receiving chemotherapy in the setting of pregnancy to monitor for intrauterine growth retardation. We also ideally would want to stop the chemotherapy 2 to 3 weeks prior to delivery. And that is because we want maternal counts to recover so that a patient doesn't have cytopenias at the time of delivery, and also because of possible fetal myelosuppression. So that would allow the counts to recover in the fetus as well. Again, if there's a situation where the health of the patient or the fetus is being compromised, then earlier delivery should be considered, even if chemotherapy was delivered right before that. And one of the questions that comes up a lot is whether or not the cancer can metastasize to the placenta or the fetus. And this can happen, but it's very, very rare. So really case reportable. One of the other medications that we often use in breast cancer is tamoxifen, so endocrine therapies. And these are really contraindicated in pregnancy. And so thus the Butara team's concern when their patient who had metastatic breast cancer and was on tamoxifen came in and was pregnant. So tamoxifen is associated with an increased risk of miscarriage, fetal death, congenital malformations, can be linked to ambiguous genitalia and a possible increased risk of GYN cancers in the offspring. So it should really be avoided in patients who are pregnant. And as we saw with the Butara team's patient, it is possible to get pregnant on tamoxifen. So, so this is something that requires a lot of counseling for patients that are on tamoxifen and maybe of reproductive age and could get pregnant. It actually decreases postpartum milk production, but is excreted in breast milk and can have hormonal effects on the infant. So breastfeeding should be avoided. I wanted to make a quick mention of aromatase inhibitors because they are one of the endocrine therapies that we use commonly in breast cancer care. They're not utilized for premenopausal women, but sometimes are used for premenopausal women who are whose ovaries are suppressed. And so this is not something that would come up frequently, but their use would also be contraindicated. Another form of therapy that we use frequently for breast cancer patients is trastuzumab. This is considered a targeted therapy. It is blocks HER2, which is a protein that's overexpressed in some breast cancers. And when trastuzumab blocks HER2, it blocks a signal that's responsible for cancer cell growth and division. However, trastuzumab has really negative effects on the fetus. So trastuzumab can affect fetal kidney development, and so interferes with amniotic fluid production and reabsorption, which can result in oligohydramnios. It can also cause other fetal malformations, including pulmonary hypoplasia, where the lungs don't form correctly, and cardiac malformations, as well as fetal death. So this medication is absolutely contraindicated in pregnancy, should be avoided, and should actually, pregnancy should be discouraged for at least 6 months after receiving this medication, because of the potential effects even several months after finishing trastuzumab therapy. A quick mention of some of the supportive care regimens that we use while treating our cancer patients. So when patients are receiving cancer care and are pregnant, they often have symptoms that we may need to manage. And the question often comes up is what other medications outside of chemotherapy are safe to give patients who are pregnant. So nausea and vomiting are things we commonly encounter in our oncology clinics. And so it's important to know that ondansetron and metoclopramide are generally considered safe in pregnancy, and those are medications we can use. We've talked a bit in the recent past about utilizing G-CSF in our patient population, and this is something that can be used in pregnancy if necessary. So if patients are experiencing febrile neutropenia and we need to use G-CSF, it is okay to do so. Other supportive medications that are sometimes used are bisphosphonates, and so those are sometimes used in hypercalcemia related to malignancy, and those are actually considered unsafe to use because of bone and renal malformations that are seen in animal studies. So that's something that we should avoid. So it's important to recognize that patients who are diagnosed with breast cancer in their pregnancy have the possibility of doing well. And the data shows that for patients who are diagnosed with breast cancer during pregnancy, when matched for age and stage, tumor subtype, and treatment, there's no significant impact on overall survival. So I think that's something that can be very reassuring to patients and families, is that this is something that we can treat, and that the hope is that we will be able to treat it successfully during the course of the pregnancy. I think the other thing we want to share with our patients is that most fetuses who are exposed to chemotherapy in the second and third trimester do fine. So they have a slight increased risk of being smaller, but the data, the follow-up data, and this is limited, but the follow-up data shows that most of those offspring have normal development and don't seem to have any long-term adverse effects from being exposed to chemotherapy. I think the other considerations that come up when we encounter a situation like this are some of the ethical, religious questions that might arise. And this can be, I think, stressful for both the patient and family, but also for the teams that are involved in the care. So one thing that may come up if a pregnancy is documented while a patient is undergoing cancer care, or if cancer is diagnosed early on in a pregnancy, is the question of termination. And that is an option that should be offered to patients. The question is also whether that's available in a particular community. And that's something that would have to be considered on a case-by-case basis. In the United States, it may no longer be offered in all of our communities. But I think that's something that we want to advocate for on the patient's behalf if they feel that that's the best decision for them. We always want to consider the fetal viability and what the outcome to the fetus will be while we're having these conversations. And I think the other trickier thing is accepting a certain amount of risk. So accepting a risk of potential fetal toxicity and a potential compromise in care. So there may be trade-offs that we make with an uncertain amount of risk, but if that is concordant with the patient and family goals, then we have to have some, accept that discomfort and that risk while caring for these patients. I think it's always important to have these discussions in context of the overall prognosis of the patient and help them to make decisions based on that information. So again, if a patient has an earlier stage cancer versus a later stage cancer, they might make different decisions. I think we always want to think about the costs, both to the patient and also the healthcare system, I think that financial toxicity and financial burdens are very real, and they may impact decision-making as well. So an additional update from the Butaro team was that the original plan for the patient that they are caring for was to stop tamoxifen and resume chemotherapy. However, after that discussion, at some point, the patient decided to terminate their pregnancy. I'm going to ask the Butaro team to update us after this about how she's doing. So just to summarize, so we have a little bit of time left for questions. When we're faced with a patient who's diagnosed with cancer during their pregnancy, the patient's clinical status, what we call performance status, their preferences and goals must be considered in order to formulate a care plan. Having a multidisciplinary team is really important in order to best care for the patient as well as for the fetus and to optimize outcomes. As much as possible, when we're thinking about breast cancer, treatment of breast cancer during pregnancy should conform as closely as possible to standardized protocols for patients who are not pregnant in order to optimize outcomes for the patient. Just to review, surgery can be considered at any stage of pregnancy if necessary. Chemotherapy is generally in the second or third trimester unless the clinical scenario and the health of the patient is in danger. And then we generally want to avoid radiation therapy during pregnancy, except in the setting of an oncologic emergency. You know, based on the data that we have, patients that are diagnosed with breast cancer during the course of their pregnancy do just as well as patients who are not pregnant. And of course, the special considerations that we always want to take into account are the patient's prognosis, their stage, the acceptability of possible outcomes to the patient and the family, and the potential role of termination if that's concordant with the patient wishes. Just going to, these are the references which will circulate to everybody. And that's it. I'm going to stop now, and so we can answer questions, any thoughts that may have come up during the course of this discussion. I'm going to stop the share.
All right, I will be monitoring the chat, but feel free to either unmute yourself, raise your hand, or type your question into the chat.
I might call on Dr. Randall, since he's our resident gyn-onc surgeon, and Dr. Millian too, if he's still on with us, about how often you might see pregnancies in patients that are undergoing cancer care.
Christoph, are you there? Do you want to comment on that from experience on the ground?
Yes, thank you so much, and Sarah, for this exciting presentation. Thank you, everybody. And the question is, if we observe many cases with, pregnancy and cancer, and we don't observe a lot of cases and associated, cancer associated with pregnancy, but we find some cases in the world. And we manage this patient conjointly with the oncology department. And as you present, I represent, breast cancer and pregnancy. most of the time, the case of breast cancer and pregnancy are managed by the surgery team. But for our case, mostly cervical cancer or ovarian cancer or vulvar cancer, we manage them conjointly with the oncology team. And we found some cases at the department, and sometimes it's really challenging, like you said, and because of legal consideration, as you know, abortion is totally contraindicated when we consider the legal situation of the country. And secondly, also it's about the cost of the treatment. Some of patients will require a high cost, and also the social context as well. And when we take into account how patient have to cross dangerous zones to come to the hospital, and we'll have to take all these factors into consideration while you try to propose the appropriate treatment to this patient. And also, mostly for cervical cancer, we did C-section, because of, and the patient, and most of the time couldn't deliver. And we did C-section for this pregnant woman. And for other cases, and breast cancer, as I said, and I defer to Lomi to talk more, because most of the time the patients are managed by the surgery team. And that's it. And happy to listen to you, Liz, or other guys here who have the experience and manage and to learn from them.
Thank you. Good morning, everybody. And currently we have a case hospitalized in antenatal ward. She's diagnosed with a invasive squamous carcinoma of the vulva with a pregnancy with a gestational age situated between 22 and 26 weeks. And see the case that I will present tomorrow morning. Invasive vulvar cancer and pregnancy. And as Millie mentioned, when we diagnose this invasive cervical cancer, we perform a C-section and then refer the patient to medical oncology. And currently we present a case with vulvar cancer that during the statistical data, I didn't see any information about the statistic report related to vulvar cancer, but we have currently a case hospitalized in Ballet.
That sounds challenging, especially given where she sounds like she's sort of just over halfway through her pregnancy. I think that the Haiti team, I think bringing up some of the additional challenges, which I didn't speak to, but that Christophe mentioned in terms of the current difficulty in moving around the country and transportation and the logistical challenges that this may present to our patients is definitely something that we also need to take into account when making these decisions.
Hey, Sarah, if I could say a couple things. Thanks for the offer about cervical cancer and pregnancy, as Drs. Millian and Ulysse mentioned. We do, especially at Mirabelet, see this small but significant rate of women presenting with pregnancy and vulvar or cervical cancer. And it's challenging because, as Christophe says, transportation is such an issue, logistics are such an issue. But I guess I want to encourage the team a few things, like certainly with anything like this, feel free to reach out to the Haiti gyn-onc team and or to me to discuss these things. Second, feel free, part of that is feel free to sort of escalate, as you were saying, Sarah, like the level of multidisciplinary care, feel free to consult your colleagues worldwide for these issues because they're complicated. In terms of gynecologic cancers, one of our biggest challenges is hemorrhage and timing of treatment. And I have no perfect answer to that, particularly in many of our settings where we don't have radiotherapy. You know, in a higher resource setting, we can do some trickier things like do interventional radiology procedures and embolize the anterior division of the internal iliac vessels or the uterine vessels or things like this. Certainly in extreme circumstances with desired pregnancy, you know, you could discuss with your surgeon just surgically accomplishing that in the setting of hemorrhage. To do like an internal iliac vessel ligation or something like this is what I would say. But overall, the last thing I just want to close with is be super careful with gynecologic abnormalities in pregnancy of hemorrhage. And so all these challenges notwithstanding, I would, you know, just think twice before getting a biopsy, certainly before conization or LEAP or something of that nature in the pregnant woman. So think about, you know, consulting one of your colleagues first. And thanks, Sarah, great presentation. Thanks so much.
Thanks, Tom. Yeah, I think the transfusion support also is always a challenge. So just to acknowledge that. We have a question, is that from Julius? You're muted. There you go.
Yes, thank you, Doc. Thank you so much for this presentation. I'm Julius, and we are from Liberia. So I want to say thank you so much for this presentation. Liberia has a very small team of oncology nurses. And here in Liberia, this is one of the challenges we have because most of our patients mostly come in late stages, even though we have not encountered breast cancer in pregnancy here. But we are actually concerned when it comes to the option for the treatment that has to do with surgery, which is actually good. But I just want to get some pieces of advice from you. What will happen to a mother who came maybe at a stage where the doctor decided to do a surgery, but then this surgery will be a radical modified mastectomy, and we have to be followed by radiation. So, and radiation is contraindicated when it comes to that. So I would like to actually understand what could be some of the approaches or what could be advised when it comes to that. Thank you.
Yeah, no, that's a really good question. So, you know, for some of these patients, if they have a localized breast cancer, surgery may be appropriate even during the course of their pregnancy. So modified radical mastectomy may be the best treatment option for them. And what I would say is if there's an indication for radiation following the mastectomy based on lymph node involvement or concern from the surgeon, that the recommendation would be to delay the radiation therapy until after the pregnancy. I think the reality is that probably the radiation could be done with minimal exposure to the fetus. And Scott can talk more about this, but the general consensus seems to be that after the surgery, there probably isn't a harm in waiting until after the delivery to do adjuvant radiation therapy. Scott, I don't know if you want to address that more particularly.
Yeah, thanks, Sarah. I would agree. I think there are usually ways. There's no cookie cutter approach to this. It really, every patient with this problem, you have to individualize the care. But I think there are usually ways, particularly when you're talking about an adjuvant treatment, of delaying it. You know, most of the time we're trying to figure out ways not to delay it, to expedite the treatment. But this is one situation where, again, you have to look at the particular situation, the particular risks. And usually you can figure out a strategy where you can push it back. So the radiation piece is going to be a non-issue.
So we are getting to time. So if there's any other questions, please feel free to send me an email or send an email to Dr. Slater. Thank you again, Sarah, for this wonderful presentation. I think that we are going to wrap up, but I have a couple quick announcements. So our next session will take place in 2 months, Thursday, May 25th. And Dr. Tom Randall has agreed to give a talk on screening and treatment of precancerous lesions for cervical cancer prevention in low and middle income countries. So we look forward to that. Again, thank you so much for everyone that joined the talk from Haiti, Rwanda, Liberia, Lesotho, the maternal health team. When Scott and I were thinking of this lecture series, we were thinking a lot about One PIH and figuring out a way to gather a community of people interested in cancer care. So thank you so much for everyone who joined. And again, thank you, Sarah, for the presentation. If you have any more questions, I'm going to stay on the meeting for the next few minutes, but feel free, again, if you have more follow-up questions, to send us an email and we can continue the discussion offline.
Thank you, Erin. Thank you for
Thank
coordinating.
you so much. Thank you. Thank you.
Great session. Thanks, Erin. Thanks, Scott. Thanks, Sarah.
Thank you,
Thanks,
everybody.
thank you all, Prof.
Thank you, everyone.
Thank you so much, Madam Martin.
Prochaine présentation, c'est le 20.
May 20.
Yeah. Côté monsieur qui est en haut à gauche, là, la présenté son gynécologue, la présenté sur diagnostic, c'est dépistage avec diagnostic cancer col. Dans le pays, quand on paye à ressources limitées. C'est la préférence. Mais
All right, and to answer Julius's question, yes, I will be sharing the recording of the meeting, and I can also share the slides with you.
Okay. Erin, I'm going to jump off to the clinic, but feel free to share my email or circulate my email if you have questions.
All right, great. Thank you, Sarah.
Okay, thank you all.
Am I coming on?